Health reform is asking for high quality, low cost, if you can deliver both. So in many ways, this cost comparison can still help providers determine where they are with costs, and eventually we will probably have a report that'll probably be measuring quality along with it. That'll be my estimation of where we go with this report.
I think historically the cost comparison has developed around routine costs, but with payment reform, with bundled payments, managed care contracts, it's becoming important to know the cost of ancillary services and what is a true episodic cost of care. And that's difficult for providers to measure. And it's going to be difficult to incorporate that into the cost comparison with any accuracy.
I can remember using the cost comparison, and I learned this lesson somewhere along the way, that sometimes less facilities was more relevant and more accurate than more facilities. Back to your accuracy thing. A pool of 300 or 400 or 500 facilities, whatever it is today, gives you a broad average. But sometimes sifting down to 5 or 10 or 15 really relevant comparative enterprises actually gave you better information than you could have gotten from the other. So I wonder if it'll evolve to something like that, Debbie, where to get to accuracy we actually shrink the pool instead of expand it? I don't know.
I think you're going to see more of the same. Pretty much government never invents a new policy or a new theory. They just rehash something they had 20 years before. I don't think we'll ever go back to cost reimbursement, but current emphasis on quality and cost and results are certainly outcomes, I should say, are part of the quality. They're going to continue to gather statistics, and you're going to see the field narrowing as far as the quality providers. There's going to be a huge amount of providers who are dealing with maybe not quite the same sophistication. Maybe they're dealing with high medical needs, but it'll be with people with dementia and whatnot. But it will remain competitive.
The whole industry has changed. It used to be convalescent care. There's a lot of assisted living, independent housing type people in the nursing home now. It's a skilled care setting, it's post-acute care, it's short stay, it's a lot of heavy Medicare reliance. So shorter stay, higher acuity, higher cost. So that's the changes, I would say, is that we've really seen a huge increase in acuity. And there are going to be less beds, but there'll be higher acuity. You'll have all kinds of options, home care, assisted living, independent housing, and with technology, who knows how seniors will be cared for in the future. You'll probably have all kinds of monitoring devices and things that are part of your body that are going to indicate to somebody somewhere exactly how you're functioning.
I think to operate a organization, a senior living organization today, it takes more expertise. Management of cost is more critical because you do have more of a fixed payment rate and you're managing the total cost of care, not just routine services. And when you're contracting with a health plan, maybe you're working with a local hospital, they're selecting the quality providers that they want to work with. They don't want to work with every provider in their geographic area. So it's more critical that organizations establish that relationship with the hospital or with the health plan. My concern is there's going to be facilities that are going to be left out because they don't have the expertise.
First of all, I think the skilled nursing facility is finding and will continue to find its place in the continuum of healthcare. There was a day, I think all of us thought that the model was going to be dead. But the skilled nursing facility continues to find its place in the continuum because there are always those who have end-of-life issues that are too complicated to care for in a home or not severe enough to happen in a hospital. They have some severe cognitive or chronic or other issues that are just required there. And now today, what we see is the rehab capabilities, which is what you were speaking to, Debbie, remarkably complex. And so we're seeing an amazing transformation actually in the country right now of buildings from being functionally obsolete to being these state-of-the-art delivery mechanisms. Many of them are reinvented. Some of them have a whole different model and delivery mechanism. But there's this metamorphosis that's going on even while the different types of care arise, the alternates. And so there will always be a place. They won't look like they did before. None of us want that. All of us want that different model. And the smart operators make adaptation. They make the capital investments expecting appropriate returns because society is demanding and requires it. And actually, healthcare reform, I believe, has been the best friend thus far to skilled nursing facilities because it's forcing individuals from high-cost settings into a very economical setting. Regardless of what we think the cost is high or low relative to when we started the cost comparison today, it's really low relative to other sites of care. But the complexity that can be cared for that cost is a remarkably good deal for the great operators. I hope that we can continue to be that asset to those great operators that we've been historically by using data that few people have because of the reach we have, locally and nationally. Because we're going to see this business continue to evolve, change, and really deliver an exceptional value. High quality, relatively low cost. Bundled, packaged, accountable, doesn't matter. It's going to be a good value, and it has been.